Well, good afternoon. Welcome to the Hot Topics session. It's always a very interesting part of our meeting. And you will see that the topic that's been selected on this occasion is on 7-day working. Now, the technology that we've introduced to this meeting enables voting. So if you would go to your iPad or other device and look down the menu, you will come to the bit that says interactivity. And you will see that there is both voting and Q&A. Now, let's do Q&A first. On the screen is the way that you can put questions, and these will be electronically conveyed to me, and during the debate we will we'll put these we'll put these to the two speakers. In terms of voting, if you click on the voting tab, you will see that the ability to vote on questions comes up. So what we're going to do is we're going to look at 3 questions. We want you to vote on them just now, and we'll do the same again at the end of the session. Now, it is very important that you do not vote until we say that you can, because otherwise it won't be recorded. So we're going to have. Can we have the first question, please? So if you look on your voting tab, number 1 is yes, number 2 is no. It's very simple. And the question is: do you think that 7-day elective working will be good for the NHS? Simple answer: 1 for yes, 2 for no. And as soon as we start, we can vote. So can you start, please? So vote now. Okay. And we should see the... so pretty balanced in this audience. So can we have question 2, please? Do you think that 7-day elective working is unnecessary? 1 for yes, 2 for no. Can we start, please? Vote now. Okay, reasonably balanced, but more think that a 7-day elective working is unnecessary. Can we have the third question? Do you think 7-day elective working is affordable? 1 for yes, 2 for no. Start, please. Vote now. And I think that was probably predictable. So, thanks very much for that. We'll have a look at these again at the end of the session. So, we have 2 superb speakers. Can introduce, firstly, Celia Ingham-Clark. Most of you will know, a surgeon, but doesn't, I think, currently practice the art. And we look forward to your talk, Celia. Thank you.
Thank you very much, John. And yes, you're right, I was a colorectal and general surgeon for 10 years. I was then an acute trust medical director, so I had to do the numbers and the money for a bit. And I now work in Bruce Keogh's team as the National Director for Reducing Premature Mortality. But I'm also the person who's been working with Bruce Keogh in the 7-Day Services Forum, and I led the group that designed the clinical standards that were published earlier in the year for acute care. And we are looking at the pros and cons of elective surgery over 7 days going forward, and I hope I'm going to be able to explain why. So what I'm going to talk about is, first of all, why we should consider 7-day services anyway, and including for elective surgery, why I think it's an effective use of NHS resources, and we're not talking about it for everybody in every situation. We're talking particularly for specialties which have a high volume of elective work, or for specialties that have a low volume of emergency work. And I want to emphasise that we're not talking about going back to the good old days, which some of us remember extremely well, of 1 in 3s and 1 in 2s, and I think there's someone in the audience who actually still did a 1 in 1, but I won't identify him. So, first of all, why should we consider 7-day surgery? Well, top of the list is clearly patient safety. We've seen multiple publications from this country and from others which show that emergency admissions at the weekend mean that the patient is more likely to die than emergency admissions in the week. And that's a massive effect. It works in other countries as well. Alongside that, there is an influence on length of stay, there's an influence on the patient experience, there's an influence on readmissions. And a lot of it seems to be around consultant-delivered care. And we've got examples from cardiology, and we've got examples from the hyperacute stroke centres that have been rolled out that show that you can actually reverse that weekend-weekday effect if you put in proper consultant-delivered care 7 days a week. So that's really important. And then when you come on to elective surgery, we were perhaps quite surprised to hear from the paper published early last year that patients admitted on a Friday or a Saturday or a Sunday for their elective surgery had a higher mortality than patients admitted on a Monday. Now, if you take that at face value, you walk away. You're not going to do any elective surgery at the weekend anyhow. However, there's increasingly some evidence, and I was pleased to see evidence on a poster from Sheffield here today, that if you put in a good enhanced recovery programme, you can abolish that weekend effect on elective surgical mortality. So there's quite a lot of information suggesting that if you have a proper pathway of care, where decisions are made by consultants in particular at key points, that you will actually deliver a more effective care pathway, and you will be able to do it over the weekend as well. Why do we think that there is increased mortality for people who come into hospital at weekends? Well, we don't know the answer. People have made hypotheses based on potential associations. We know that the overall level of staffing is lower at weekends. The nursing staffing may not be very much different, but the number of medical staff and the number of physios, pharmacists, etc., is lower at weekends than it is in the week. We know that there are fewer consultants around, and it's the consultants that make the decisions. If you look at the bottom of this slide, the Academy of Medical Royal Colleges has said that consultants add value through diagnosis and ensuring timely transit along the pathway. So having a consultant there to make sure not only that the person gets the right treatment to start off with, but that they progress through that treatment promptly is really important. There's certainly an issue about support services such as diagnostics, and hospitals that have introduced better access to urgent diagnostics at weekends have been able to improve patient outcomes and their pathways. And this brings us back to one of the slides one of my earlier presenters today, Mike Grocott, showed, which was about failure to rescue, so that if you've got a person who's an inpatient and they're going off, you've got to A, recognise it, and B, do something about it in order to reduce their risk of dying. And of course, it may be due to the community and primary care services, which tend to be less robust at weekends, so a patient may become more sick before they come into hospital at that time. But either way, we believe that having consultants around at the weekend is going to make a difference. There's also public expectation in all of this. So you expect to be able to do your shopping any day of the week. You expect to be able to sort out what's happening in your bank account any day of the week. And patients, where given the option, are very keen to have things like day case surgery at weekends. It's more convenient for them. And if they're inpatients in the hospital, they certainly expect to be seen and have their pathway progressed by someone who is a senior decision maker, and not to sit around from Friday till Monday waiting for the next consultant ward round. And you'll be aware that the Academy of Medical Royal Colleges has agreed 3 standards on 7-day services. And the first of these says that hospital inpatients should be reviewed by an on-site consultant at least once every 24 hours, 7 days a week, unless it has been determined that this would not affect the patient's care pathway. And this applies to emergency and elective patients. And I know that many of you on the ground are now going in and seeing your patients 7 days a week. So the emergency side, we're there. We have to do it. We've also had patient feedback direct to NHS England. Patients saying they don't like the waits, patients saying they think their care has deteriorated because they didn't have consultant input. So there's also the staff side of things. So the Royal College of Surgeons of England produced a report several years ago now stressing the importance of senior surgeons for both elective and emergency work at weekend to ensure patient safety and the quality of care, to ensure appropriate supervision of trainees, and also potentially to use that time for teaching. And it gives you the opportunity to align the consultant with their trainees in the same team, which improves the bonding, improves the performance, and therefore improves the quality of care. If you run regular services at weekends, it also reduces the Monday morning chaos. So the radiology service in Torbay, the acute medical service at Addenbrooks, and the pharmacy service back at my own unit at the Whittington in North London, having changed some time ago to running a 7-day service for routine work, would not go back because they've done away with the Monday morning chaos and they can manage their patterns of work better. So people quite like to do it once they've changed. Now, we've also got a productivity challenge. So we have the call to action in NHS England in 2013. We know that we've still got a funding gap to fill by 2020. So we have to be very careful about our use of money. However, we are in a situation where the demand on our services is going up. The number of referrals for elective operations is going up by an average of 3% per year. We know that organisations are actually struggling to actually meet the demand that's placed on them. So a number of units, some of which I suspect are represented in this room, are struggling to meet the 62-day standard for cancer care, and also units are struggling to meet the referral to treatment time, the 18 weeks. So the number of people waiting for treatment after 18 weeks is the highest as it's been for the last 2 years. The number of people still waiting after 18 weeks is going up. It's gone up to 169,000 towards the end of last year. And the number of people on waiting lists is going off the scale. So the demand has gone up. So how do you deal with rising demand? Well, your choices are to turn it off, in which case we'd be rationing procedures, or to deal with it. And if you're going to deal with that demand, you have to put in additional capacity, and your choices are to do it on the NHS or do it some other way. So those are the choices that we're faced with. And we know that in many units, people have had to deal with that challenge over the last few years. They have done waiting list initiative work sporadically, which is an expensive way of doing it, or they've sent the patients off to be done in the private sector, which may line individual surgeons' pockets but doesn't actually save money for the NHS. We also don't want to leave operating theatres standing empty, because of course the other way you could put in the extra capacity would be to build more operating theatres. But why build more operating theatres when you've currently got some standing empty for 2 days of the week? And in fact it's not just 2 days, is it? Because your elective theatre isn't used out of hours either, so out of a 168-hour week, a single operating theatre can be empty for 120 of those hours. We know that 2/3 of trusts already run 3-session days in order to deal with the demand. We know that many trusts are doing routine endoscopy, CT, MRI at weekends, and the financial modelling supports that because the more cases they do, the more money they're bringing in for the organisation. We know also that 10% of trusts are already doing routine elective lists at weekends, and those are almost all foundation trusts. They tend to have canny finance director, so there must be something in it. So it's an opportunity to generate additional income. The cost of paying the overtime for staff is less than the cost of building additional operating theatres. For low-volume emergency specialties, for example, ENT, can make a very good argument for somebody coming in to do a routine clinic or a routine list at the weekend, and then when they're on site, the additional cost for them to see the 1 or 2 emergency admissions in that specialty in the day is very low. I know that wouldn't work for the high-volume acute emergency general surgery. And that type of approach of enabling someone to cover some emergency and some elective work at the weekend, where the elective work is low volume, was recommended in the Royal College of Surgeons report. And people in private practice are tending to do weekend work as well. Now, we know that we've already got the 7-day services clinical standards addressing acute care. That work is going forward. Those clinical standards are going to be built into the standard contract for hospitals to deliver from April next year, and I know that many hospitals have already made a difference in terms of moving that work forward. We've got to look at it for elective as well. So, I don't know if anyone in the room recognises this gentleman. Anyone tell me who this is? He's not actually a surgeon, although he might look like one. That's right, it's Lord Beaverbrook. Thank you. And he is apparently the first person to whom this particular story is ascribed. He was sitting next to a woman at a posh dinner, and he asked her, "Madam, would you sleep with a stranger for £1 million?" And she said, "Well, yes, I suppose so." So he said, "OK, Madam, would you sleep with a stranger for £5?" And she said, "What do you take me for?" He said, "Well, we actually know what you are, we're just negotiating on the price." So, from a practical point of view, there are people in this room who are being paid a lot of money to do routine elective work at weekends, and there are other people in this room who are doing routine elective work at the weekend already within the current consultant contract. Whether or not it's affordable for the NHS partly depends on your professional behaviour. So I'm looking at your consciences here, guys. So going forward, as surgeons and doctors, we want to provide the highest possible quality of care for our patients, and we have to have due regard for the cost. We need to have high-value care that is high quality with as contained cost as we can manage. We know we've got to do emergency work 7 days a week. We know we have to review the inpatients 7 days a week, and that will make a difference for our patients. I've given you some examples of opportunities that we could use to actually deliver routine care at weekends as well. And we need to eliminate that weekend effect, which is so shameful when it crops up in the national papers. I believe it's ethically unjustifiable to provide a lower standard of care to patients at weekends than on weekdays. And I believe that we can deliver that 7-day service in a cost-effective way. Thank you.
So, Professor McPhee, Chairman of the Surgical Forum, is going to give a different view, possibly.
Well, I might not, Mr. President. I enjoyed that very much, Celia. I'm now completely converted to your cause. I just wish that more in the Department of Health were as erudite as you are and as persuasive. But for the sakes of debate and some entertainment, I'm going to put an alternative view, particularly since the chairman of the scientific committee specifically said I have to address the issue of cynical spin. So 7-day services, you've told us very clearly what the party line is on this. It's the NHS business plan, it's NHS England. Patient care is poor, it's unsafe, it's disorganised. You've said that, you've given us some data. And you've also said, which I predicted your talk, it's what patients and it's what staff want. So you tell us. But actually, this is all from the government, all from the CQC. And the benefits you've highlighted very nicely. Apparently there's quicker decision-making, better decision-making, fewer delays for patients, shorter lengths of stay, fewer complications. It optimises the use of expensive equipment. It's argued that there's better training, and there are said to be fewer bed pressures. But all these perceived advantages of 7-day working come from the CQC. So what about the hype? Because there is a lot of hype over this, and that's what I've been asked to address. We get these emotional comments repeatedly told us in the newspapers. More people die at the weekend, we're told, particularly after surgery. Well, it's certainly true that more people die after surgery. That's absolutely right. The man with a knife shortens your life. That is unquestionably correct. Why should a patient who needs health care or social care be treated differently on a Sunday or a Tuesday? That's the emotional blackmail that the Department of Health puts before you as a group of professionals. If a girl discovers a breast lump on a Saturday, why should she have to wait until after the weekend to get it sorted? That's a quote from Bruce Keogh. I find it marginally offensive because it's emotive again, and I don't think it's evidence-based, and it appeals to your heartstrings. Or another quote from the Department of Health, "Sweat your assets. We can't afford to have expensive resources lying idle." You're all intelligent people. You know that you want to sweat assets, but there has to be some recognition of the practicalities. Or, and Celia made reference to this, this is a quote from the Telegraph, "I'm familiar with having to sort out the chaos of weekend admissions on a Monday." I'm amused to see the fact that Celia quoted it from 2007, which suggests to me that it was a previous president of the college that made that comment. But actually, that comment there was taken from the Telegraph about 2 months ago from our current president. And I fundamentally disagree with that, as I hope all of you in this audience will disagree with that. Because if you have to go in on a Monday and sort out chaos, it means that you didn't do your job on the Saturday or the Sunday. And I would put it to the Department of Health that that's an insult to most practicing surgeons. This is what we're told: equality for all. This is an NHS document. NHS improvements up there in the top right-hand corner. We then get NHS improvement again. We're told it's got to be improvement. We're told the document's called equality for all. In other words, we're encouraged in the principles of egalitarianism. Perhaps it's a remnant from the departing chief executive, who was, after all, a member of the Communist Party. Delivering safe care. Does anybody here deliver unsafe care deliberately or maliciously? I think this is shameless propaganda. And all the examples within this document, which for my sins I have read, all relate to the fact that those units, be it stroke care or whatever else, have had increased resources. So, ladies and gentlemen, cynical spin or efficiency? Is 7-day services cynical spin or efficiency? Is it motherhood and apple pie? Is it so blindingly obvious that expensive operating theatres should be used 7 days a week that we haven't got the temerity to challenge it? Or is it the emperor's new clothes? Because this has been told that we have to do this by the college presidents, by Bruce Keogh, by Uncle Tom Cobley and all, that we're not allowed to challenge it. To challenge it would be incorrect. Or is it something simpler? Is it just, as I think it is, just another slap in the face of our professionalism? So let's look at the arguments briefly. The arguments surround basically mortality at weekends, 7-day elective provision, and optimal use of resources. Mortality. Celia's mentioned mortality. This was the original Dr. Foster data that led to all the newspaper cuttings and remarks. There is unquestionably in that data higher mortality at weekends. That is unarguable. It is a fact. However, if you look at what happened after this, it led to an amazing series of articles in the press. These are taken from the Telegraph. Increase in mortality related to heart attacks went from 20 to 28% at weekends. That is an absolute rise of 8 percentage points, but relatively speaking, is a 40% increase. Now, I'm not sure how much of you are keen on statistics, but don't you see the hype here? You know, it's gone from 20 to 28%, so they put 8% over 20 and said it's 40%. This is spurious. They do the same for aortic aneurysms. Well, there's anybody here from the Vascular Society, I think they take great umbrage at that. And carcinoma of the pancreas. I cannot think of any situation whereby carcinoma of the pancreas would undergo elective surgery at the weekend. All this is inappropriate statistics. It's reminiscent of the famous Minister of Health, Secretary of State for Health, at the time of the Bristol heart scandal, who said, when he was appalled by the results, he said, "I will make sure, I will endeavour, I will insist that all cardiac surgeons are above average," clearly indicating a certain lack of knowledge of statistics. You're getting it, above average. And this was the article that followed in the BMJ from Goddard and others that was based upon the Dr. Foster data. But there are certain caveats to this data which have been expanded upon now extensively. They accepted, Dr. Foster that is, that the data they expressed there, that many of the patients that admitted at weekends were sicker. Because you have to distinguish between both mortality but also admissions. Approximately 50% of the patients who died on a Saturday and Sunday were already on a Liverpool Care of the Dying pathway. So the patients were sicker. And much has been made about this business of consultants, but actually the definition from ST3 for senior doctors was ST3 and above. And I'd refer you to that BMJ article. As I'm sure most of you know, if you go online, there's a thing called rapid responses. And in the week following the article, there were a large number of responses, but I draw your attention to two of them. One from the BOA, trauma, 1,000 patients with a fractured neck of femur. They found no weekend mortality effect. Cardiac surgeons, 93,000 elective cases compared to 3,500 emergency cases at the weekend, no effect on mortality. So the evidence is not as powerful as it's made out that there is a significant difference on mortality. And that then takes me to the point that's already been made, that there's this continuing banging of the drum that we want consultants present in hospital because of better decision-making and so forth. But I put it to you, ladies and gentlemen, that the correlation between senior medical input and weekend mortality oversimplifies a rather complicated and multifactorial system. But in addition, if we look at the data, hard data, this is an NCPOD report from 2011, a review of the risk, a review of the perioperative care of surgical patients. You all know that NCPOD relates to case reports. You know there's been 20 or 30 reports. We tend to rely upon the data. There's their evidence for grade of a surgeon being appropriate. In 98.9% of cases, NCPOD declared that the grade of surgeon present at an operation was appropriate. And the same applies with anaesthetists. 95% of anaesthetists were appropriate grade. And if we look at specifically, that relates to consultant presence. And this is the same. This is the National Emergency Laparotomy Audit, which is ongoing. I'm sure many of you will have contributed this. And this shows the data for time of day and consultant presence. Anesthesia, surgery in red, and mortality. You can see during the day there are consultant anaesthetists and consultant surgeons present in about 80% of cases, which drops to about 60% in the evening. And at night, it's still 60% for surgeons. Now, most of the other cases in this audit were things like abscesses and so forth. So I completely and utterly refute the allegation that consultant surgeons are not present in the emergency room at weekends in this country in 2014. So let me go on to 7-day elective provision. We can rehearse the arguments extensively. I'm going to be very brief. One of the things that I'm interested in terms of this is bed occupancy. We could look at theatre occupancy. Care Quality Commission have said that bed occupancy in England and Wales is sometimes greater than 102%. Before the sheets have got cold, there's another patient into beds in our hospitals at the moment. The Department of Health data from 2012 recognised that bed occupancy in this country runs at 87%. The National Audit Office on Healthcare-Associated Infections declared that bed occupancy levels in England and anywhere should never exceed 82%. The President of the College of Surgeons said recently the government's made a great start by publishing weekly infection rates. The public can now get a clear idea of which wards are overcrowded. Bed occupancy rates above 82% are a clear predictor of an increased risk of infection. The RCS remains committed to seeing bed occupancy rates fall. This is completely at variance with a 7-day policy of elective services. And again, we've heard reference to optimal use of resources. Well, this is the Health Service Journal. This was December 2012. The CFWI, the Centre for Workforce Intelligence, that well-known oxymoron, Centre for Workforce Intelligence, estimated a 60% increase in the consultant salary costs if the NHS adopted a consultant present service. That's equivalent to £2.2 billion a year in consultant wages, up from £3.8 billion in 2010. The NHS budget is £104 billion and there are no plans to increase it. So, Celia, I've got no problems with the concept of 7-day working, but we need to have some clarity and some honesty from government as to where it's going to be funded. Because at the moment, politicians are imploring us as a profession to go along with this. Our chief executives are telling us we must go along with this. And it's all against a background of massive service pressures. Extensive loss of acute beds, rise in emergency admissions, A&E services overwhelmed, ineffective primary care. All this is a reality in the modern NHS. Reconfiguration is happening. Every time a small hospital closes, there's a domino effect on other hospitals to become busier. We've heard the generalist specialist debate. There's lots of people retiring early because their pensions are not as rosy as they used to be. We've heard reference already to the target culture. You know, we hear repeated talks about we don't want repetitions of mid-Staffordshire, but mid-Staff's occurred because of a target culture. It's no good, as say, one of 7-day working to meet an 18-week or a 60-day target unless we resource that facility. Because we have a demoralised consultant workforce. Most consultants in my hospital, in the units that I go to, feel miserable. They feel fed up, they feel oppressed, they do not wish to do any more work. There are other arguments against, apart from cost. Social and domestic disruption. Why should people not have their weekends off when their family are off? Service loss in the week is not necessarily more efficient. Darcy centres were an example of this. They did not work. There are problems with 7-day working, with planning management, MDTs and governance meeting. And I think there's an adverse effect on training. Rota management, availability of transport, absence of social services are all reasons why, without resourcing it, 7-day working cannot work at present. And I've got one or two other gripes about this. I really don't like the moral blackmail that is put on the surgical profession, that it's good for the patient, it's good for morale, it's good for waiting lists. You know, surgery as a profession has pushed its backs to the wall already. We hear frequent people in positions of influence who are worthy. They say, this is for the patient benefit, it's in the patient's best interest. Well, I beg to differ. There's nobody in this room who doesn't go to work with the patient's best interest at heart. We don't need to be told about that. We don't need to be lectured about that. You need to have a word with Bruce Celia and tell him to stop using the word compelling, because he's always saying the data is compelling that we should have 7-day services. No, it's not compelling. It's compelling in a voxpop way that it appeals to the Daily Mail reader or the Daily Telegraph reader, because they cannot see the logic of not having the operating theatre open on a Sunday, because they don't see the logic that if you want to do that, you need to significantly increase the number of staff that the hospital employs. And it's at variance with government diktats that say, you and I should all be paid 10 PAs. How many of you here are working the equivalent of 14 PAs, but being paid 10, 11 or 12? Now, Celia did say she doesn't expect you all to be working 7 days a week, and I accept that completely. But the government needs to make that tacit recognition that 7-day working will only work if there is a substantial increase in resources. So this cynical spin, which makes us hard-working surgeons look bad if they object, and that is my objection to the initiative that's been put out at the moment. But in response to the director of the scientific programme, is this cynical spin? Well, surely not. Would the government be guilty of spin? Surely not. They're a group of honest, law-abiding, respectable individuals. Remember this, a named GP for every patient with dementia. We have millions of patients with dementia. What happened to that initiative? Half the number of mistakes in the NHS will save 6,000 lives a year. Well, it sounds fantastic, doesn't it? It's going to stop you making mistakes and making me mistakes. It's voxpop. £50 million GP access fund to enhance care of the elderly. Have any of you seen that? Anybody seen any consequence of that? All patients will be able to access the GP outside office hours. Does that happen in your region? Is that now a reality? Only last week we heard that NHS procurement will save us 500 million. Well, I'll believe it when I see it, particularly when I look at the procurement from the trust that I work in. Care data database, trawled out with unhealthy, inappropriate rapidity. No one knows about it, consent's not been asked, but we're all told it will benefit patients and have massive research benefits and be cost neutral. Chinese medicine should be available in the NHS. That's the voxpop. That's the cynical spin. So I'm opposed to the government initiative of 7-day elective services because I think it's inadequately resourced and it's been put to the profession in an inappropriate way. Thank you.
So there you have it. Time for questions, some debate, and then we're going to do the questions again. We've got some on the screen here, which I will read, but does anybody want to come to the microphone while I'm doing the first one? So let's just deal with this one. 7-day elective and 3 session days could be possible, but surely we'd need more consultants and therefore also more trainee numbers. However, job numbers for both consultants and trainees seem to be reducing. Whoever is doing manpower planning does seem to work in the same office as the people planning 7-day operating. Comments?
Well, if I may, first of all, if what Professor McPhee says is true and you don't need a consultant to do all these operations, then that would save quite a lot of money, wouldn't it? Although I don't actually agree with that. So I'm afraid you were arguing slightly against your own cause there, John. The manpower planning is really difficult. Health Education England has a big role in that, and I agree it's not joined up at the moment and it does need to be joined up. And it hasn't been right for the last 40 years. At the moment, in quite many branches of general surgery, we have more people coming through the training system than there are consultant jobs for them to fill. So this would be a good opportunity for people to undertake appropriate reconfiguration, to staff appropriately for the work they know they're going to need to do. And so I'd encourage anyone who's responsible for setting up consultant posts or other senior posts in their organisations to get on and do it.
John?
Well, I think I've answered that in my talk. I certainly didn't say that I thought consultants shouldn't be operating, Celia. That's putting words in my mouth. I've made the point about consultants and resources. Yes, there are a number of trainees coming through, and it's true there is a slight mismatch between numbers of trainees anticipating a CCT in general surgery and consultant jobs. But I remain by the thesis that I've said. We need to have substantial investment if there's going to be an increase in trained doctors. The word consultant is a side issue. We need a lot more trained doctors if there's to be more elective operating.
David?
David Jones, I'm one of the English College's Directors of Professional Affairs, and I've got an example of some cynical spin, lack of equality for consultants and potentially a slap in the face for new consultants, which follows on from Celia's comment. And one of our remits is to approve job plans submitted for approval for new consultant posts. And I've seen a couple now, but a recent one that's been discussed at the college is a trust that's asking a new consultant to work every Saturday. So their routine operating list is every Saturday. And this was bounced by the RSPA. It was bounced by myself. Advice was sought as to whether this was legal or not. The trust were advised that, as you said, we think team working is crucial. We thought that this didn't encourage good team working and thereby threatened patient safety. But basically, the trust have put two fingers up to us. So that's how the 7-day working is being interpreted, and that's not. One of the ironies is the clinical colleagues in that trust probably support the appointment so that their new colleague would work every Saturday.
So, Celia, would just to make it absolutely clear, would you support the contention that we should be employing consultants who work every Saturday?
Of course not.
Right. So there's a disconnect between what you're saying and what trusts are doing, or attempting to do.
Well, I wasn't here to represent a trust
today,
was I?
I appreciate that.
I think
you make your view very clear.
That to be absolutely fair, both to patients and to consultants, it seems appropriate to share work fairly amongst various members of the team. While there may be a degree of protection for extremely senior consultants in one form or another, nevertheless, if we want to do a good job, we need to all keep up to speed with how to look after emergency patients when we are doing clinical work, and therefore the work should be shared out appropriately.
So, a sent question, would you suggest that Saturday and Sunday working should be paid at out-of-hours supplement?
As you know, in the current consultant contract, they are in most organisations, although not all. I don't think it's something I can comment on at the moment because, as you know, the consultant contract is under negotiation and I do carry a role with NHS England, so I can't make a comment on that.
Okay. Microphone 3.
Hi, Dermot Wynne. You can dismiss my views. I'm a medical director and you can say I'm on the dark side and the like. But actually there is a reality check. I mean, let's not pretend that everything that goes on at the weekend is as it should be. Yes, John, I agree with you. None of us come to work to do a bad job. We all have the interests of patients at heart. But there is a problem at the weekend, and we can have a little sporting debate. But actually, wouldn't it be better if we were coming up with solutions and actually saying, well, here is a problem, here are things that we can do, this is feasible, this isn't feasible. But the tone of this debate is very negative. I'm not here to make people do things, all sorts of unsociable hours, but there are problems at the weekend. It is not as good as it could be. It is not as good as we'd like it to be if we were the patients. And can't we move on from what to me is a very negative debate and actually move on and say, well, let's try and make something better. And yes, there are real problems. It is not easy. It is not cheap. But this, us against them, of the NHS versus us as surgeons, really doesn't help.
I'll answer that.
Well, I was going to say as chair, I do not actually recognise what Dermot said about the negativity of this debate. I think probably most of us would accept that at the weekend things could be better, and I would certainly accept that. I think we're talking about doing going somewhat beyond that, which is doing routine elective surgery regularly at weekends, and I think that is where the debate is. I think all of us here gathered do regular weekend work. It's nothing unusual. We've also done. I'm frankly insulted to be, portrayed as someone who never sees my patients at weekends. I'm in the hospital practically every weekend for the last 30 years. So, personally, I have no difficulty doing weekend work. But the question is about elective surgery, and that's where the debate is. So please feel free to comment.
So, yeah, I think you are on the dark side, David. So that's my first remark. The second, I don't think this is an M&S, and I don't agree with you about the tone of the debate. I agree with John. I think, though, when you're saying you want to be looking to other ideas, to innovative suggestions, I agree with that, but that was not our remit. But, in response to your question, for debate, I think that one of the problems we have in society is that we unreasonably jack up patient expectations all the time. And that relates to the gatekeeper effect of referral. So I think that, it's inappropriate to say we have this number of people on waiting lists without looking at the nature of people on waiting lists, because I suspect a lot of them wouldn't have been there 10 years ago. So that's something to be looked at. Secondly, as you know, I feel very strongly that there are ways we should be changing the provision of elective services and emergency services. I think that we need to be looking at the way we train people and what the end point of training is. And those are debates that we can quite willingly have with government. It's the Greenaway issue. So, yeah, I'm happy to look at other strategic thinking.
It's a couple of sent questions. Elective surgery, how does this affect SPRs in terms of assisting stroke perform and taking into account EWTD and time off during the week?
Well, I think some units now are trying to split the work of trainees so that they do their emergency work in a block, say a month at a time, and then their elective work over the next 3 months, so that they would be able to be aligned with consultants for their elective work whenever that is. It's clearly important that they have access to that. And one of the difficulties that we had in the previous regime, where elective surgery was sent out to independent sector treatment centres, particularly, for example, joint replacement surgery, was that trainees had no access to it at all, and I wouldn't wish to go back to that.
So there's a comment that relates to that. So the National Health Action Plan and others have highlighted the steady migration of profitable elective services to private providers. If we do not embrace 7-day services, are we not going to see these private centres do so instead, leaving the NHS with less resources and an increasingly complex set of patients?
Well, absolutely. And if I may also just refute one comment that John made earlier on that, 80% of elective surgery is day case surgery, so it should be possible to do elective work at weekends without it impinging on the inpatient bed occupancy.
I don't think you'd find it'd be 80% in most trusts, Celia, not all day, not all elective
That's the average
surgery.
across the country.
I think most of us here would not agree with that.
Mr. Vice President.
That probably relates to endoscopy.
If I could make a point, and I'm puzzled by what Celia says. Probably like many of the surgeons in the room here, I work an emergency rota 1 in 5. So I'm in every 5th weekend. The juniors are there, but all the weekend work, emergency work, laparotomies, and at night are done either by the consultant or under the consultant supervision. So we're already in a significant amount of the time. Yeah. Are you suggesting that we actually come in more often, that every other weekend, every 3rd weekend? Because in the absence, well, you're shaking your head there. Who's going to do the work?
Okay.
When we're already there.
This is about 7-day services, not about 7-day working. It is not about expecting anyone to work beyond the 48-hour week of the European Working Time Directive.
We already expect that. All the consultants in our trust have opted out of the European Working Time Directive to facilitate the delivery of emergency services. We've already volunteered to do that. Many of my consultant colleagues would work in excess of 60 hours per week. Sure. So do you want them to work a few more for the good of the nation?
No, absolutely not. Well, and I didn't suggest that.
Well, you did, because who's going to do the work?
You need enough surgeons to do the work that needs to be done. If we have to do...
Are you suggesting appointing more staff then?
Yes? We may need to, yes, because the demand is going up by 3% per year, and therefore we need to have enough surgical staff in order to do the procedures that need to be done. I think there is something in what Professor Grocott said earlier about having better shared decision making, so some people choose not to have some elective procedures, but notwithstanding that, the demand is going up. We need enough surgeons to do the work, and we need to make sure that we're very efficient in the way we utilise operating theatres around that.
So we will take it then that there will be increased funding available, despite the fact that this programme is supposed to be, I think, to quote the government, cost neutral.
At the moment, the funding mechanism for elective surgery is paid through payment by results, which means that if you do another 100 cases, you get another 100 aliquots of money. The financial arguments stack up.
So who's going to pay for the extra staff to do the work you've just said?
The trusts that are getting the additional income. Unless the taxpayers in the country decide that we should be rationing elective surgery, in which case that's going to be a difficult route to go down.
I think you'll have to forgive our cynicism. We've heard this phrase before, the cash will follow the patients. We've yet to see it happen.
It happens in every trust, every day.
Not in our trust. And I think our trust is very typical of most of them.
So can I make a couple of comments, some of which come from the audience? We've been talking really about surgery here, but a hospital is more than surgery, and the only way you can do safe surgery is for everybody to be in. Now, I do weekend ward rounds. I have a patient who needs physiotherapy. I phone the physiotherapist. There's one on for the entire trust. Can't be done. So that's not good. But who is going to pay, Celia, for running the entire hospital at the weekend? I mean, this is an order of magnitude more money than we conceive is going to happen.
Okay, having the physiotherapists available to do mobility physio on the wards at weekends, and the pharmacists and the speech and language therapists and so on, is already being built in. In London, we brought it in 2 years ago, and it's in the contracts now, and the money has been found to do it. It is in the National Clinical Standards for Acute Care and will be in every trust in the contracts from next April.
Right, okay. Microphone 3, Tim.
My comment is about more macroeconomics, I suppose. 3% increase in demand, 20 billion funding gap between 2010 and 2015, probably a 50 billion funding gap with flat increases from 2015 to 2020. I just don't see where the money is going to come from to pay for this change. And, to be frank, there's probably better ways of spending the money.
Yeah, well, it is a political question. You're absolutely right. I was interested to hear the new Chief Executive of NHS England, Simon Stevens, who presented for the first time at the Health Select Committee in the Houses of Parliament earlier this week, suggest that it is likely that the country may decide to ascribe a larger sum of money than flat cash towards the health economy by 2020.
Do you believe that's going to happen?
I'd be very interested to see. I would certainly support it.
Okay. We have, obviously a lot of this revolves around data, and the concept that the data shows that mortality is higher at the weekend, which may or may not be right. But I think just based on one's own clinical practice, The Friday afternoon phone call from another hospital that brings in some horror that's been sitting in the hospital all week, it seems to me to easily account for increased mortality in my service. Could it be that all of these data are actually just artefact?
Yes, it's possible. We don't know for sure. What we do know is that we have to have a focus on avoidable deaths in hospital. We have to try and work out what the reasons for those are and try to mitigate those, because whenever any study has been done in any developed country, they have reckoned that about 10% of deaths in hospital may be avoidable. And we will have data on that for this country from the end of 2015, robust, reliable data going forward, which is across the whole country. I would very much like us to improve the position before we get those data, rather than waiting for the data to force us to change. The National Emergency Laparotomy Audit is a really good example of that.
Okay, microphone 4.
Ilhami Bodadi. I work in the consultant surgeon, Noble's Hospital in the Isle of Man. In my hospital, there is extreme inefficiency in utilizing actually lists during the week, the elective lists. We don't do evening lesson, whatever. I'm sure this is happening all over the country. So before really going to work in the weekend, shouldn't we sort that out before extending this mess to the weekend as well?
It would certainly make sense to use the theatres efficiently in the week first. I don't think it's necessarily the case that every hospital around the country has to do weekend work. It will vary by sector. It would be daft to start doing weekend lists if you're not using theatres efficiently in the week, and that includes the Friday afternoon tail-off that many of us are familiar with.
There's one comment here which don't necessarily think I support, but could it be the general reduction in efficiency of working relates to the patient safety agenda?
Do we know there's a reduction in efficiency of working, or is it just that we've just started measuring it? I think where people have measured particularly the use of the WHO surgical safety checklist, I've seen published studies that show an improvement in utilisation and efficiency through the use of that.
Okay. Getting towards the end, I think. Microphone 4.
I'm Rosie Stanton. I'm an Oxford Deanery trainee. I want to understand a bit more what benefit this is going to bring, because I do agree that there's a lot we can improve in surgery, and I'm really sorry to feel this way, but my experience is the physicians don't see their patients every day in the week, let alone at the weekend. And if they were addressed, wouldn't there be a much greater improvement in survival across the country than us tacking on a bit extra at the end?
Now, I think that's a sensible comment. See, orthogeriatrics has made a dramatic effect, both emergency and elective orthopedics. And certainly in my working practice, we find the use of care of the elderly physicians makes a dramatic difference. But it comes right back to this recurring theme, which, Celia obviously recognises. We need to have more resources to have more acute physicians. Yeah. And I'm not trying to duck the issue of acute physicians, but our remit was to talk about surgical services. But I agree with you, there's a major issue with acute medicine.
Yeah, I mean, that's already addressed in the standards that have already been set and are being put into the national contracts from April next year. So all inpatients will need to be seen, all inpatients who are on acute medical wards will need to be seen by a consultant twice a day, and all inpatients will be expected to be seen by a consultant once a day, unless there's a very good reason why not. That applies to all specialties.
Okay, so thank you very much. I think it's been a well-mannered, well-tempered debate with reasoned argument and no rabid foaming at the mouth. Could we have a look at our questions again and just see what the audience now feels in respect of the arguments? So, do you think 7-day elective working will be good for the NHS? You recall it was roughly balanced before. Can you start, please? And vote now, thanks.
Because all the people who voted before have now left. Yes, they're serving wine.
Yeah.
So, quite a dramatic change, I think. Right, next question. Do you think 7-day elective working is unnecessary? Start, please.
the same as it was before.
There's a pattern emerging. Next question. Do you think 7-day elective working is affordable? I guess we hardly need to ask this, but just let's do it anyway. Please start. Vote now. So Celia, I think despite your eloquence, which none of us would doubt, and speaking to the audience that in medicine is likely to be by far the most receptive to your agenda, it doesn't seem likely that everybody is going to be persuaded. And we wish you great luck with our medical colleagues who, as one of the commentators said, don't even see their patients during the normal working week, let alone at weekends. So thank you very much for coming and for your participation in the debate. It's been an excellent talk. And the prize-giving session and the drinks reception is about to commence. Thank you very much.